Hello, and welcome to the presentation on lower limb regional anesthesia. Over the next 40-45 minutes, we are going to look at most of the nerve blocks which can be helpful in our daily practice when we deal with injuries and interventions involving the lower limb. Now, we know that the upper limb is supplied primarily by the brachial plexus, but two plexuses, lumbar and sacral, give out nerves to the lower limb. Central neuraxial block has been the method of choice to provide lower limb anesthesia, analgesia for a long time. But of late, we find many patients on blood thinners, and more surgeries are done on daycare basis, requiring early functional recovery. That means no urinary retention, hypotension, or motor weakness, as follows. Spinal block is a big no-no. And of course, we have had technological advances in the form of peripheral nerve stimulator and ultrasound guidance to help with our nerve blocks. Dermatomal charts are helpful, and not only them, but also the muscular and the bony nerve supply of the part which we intend to block. So they are important knowledge base before we embark on lower limb anesthesia, peripheral anesthesia. There are three nerves from lumbar plexus, femoral, obturator, and lateral femoral cutaneous nerve, and two from sciatic, the sciatic nerve, and the posterior femoral cutaneous nerve of the thigh, which are of importance to us in lower limb regional anesthesia. Lumbar plexus is formed by ventral division of L1 to L4 with contribution from T12 and L5 as well. It is a triangular shaped plexus. In this position, it is triangular as it descends from its origin in the lumbar spine towards the pelvis and the thigh. Obturator nerve is the innermost and is separated by the belly of psoas major from femoral and lateral femoral cutaneous nerves, as these two run on top of the iliacus muscle. Lumbar plexus is formed in the psoas muscle as the ventral nerve roots come out to lay in the plane between posterior 1/3 and anterior 2/3 of the muscle. Here nerves form, and the obturator nerve may lie outside this fascial plane in about 50% of population. Psoas major is located anterior to the transverse processes and lateral to the body of the lumbar vertebrae, from where it takes its origin. So then the plexus lies anterior to the transverse processes by about 1.5 to 2 centimeters. The depth from the skin varies according to the body habitus of the patient. Lumbar plexus block results in anesthesia of the anterior, medial, and lateral aspect of the thigh and medial aspect of the leg, supplied by the saphenous branch. It blocks all lumbar and some sacral nerve roots. It's a helpful modality for post-THR analgesia, and when combined with a sciatic nerve block, it can result in blockage of the whole leg. And we have used this this combination to carry out surgical procedures in very extremely high-risk, poor-risk patients, moribund patients, without the need for a general anesthetic. There are different approaches to lumbar plexus described from the back. And so basically, the landmarks are that there are three lines which we need to draw. Line one is in the midline, overlying the spinous processes of the lumbar vertebrae. Line 2 is a line parallel to the line 1, passing through posterior superior iliac spine, and line 3 is the Taffier line or the intercostal line. Now, Winnie described in 1973 his approach to lumbar plexus, and according to him, the intersection of lines 2 and 3 was the point where the needle needs to be inserted to target the lumbar plexus. It is supposed to hit the transverse process of L5, withdrawn and then redirected caudally. Chain described another approach in which the transverse process of L5 is again targeted, but then the needle is redirected cranially. Decree, in his approach, described um, a needle insertion just 3 centimeters lateral from the midline, striking the transverse process of L3 and redirected caudally. Capdevila modified Winnie's approach, and his needle insertion was on a line joining the line 1 and line 2 at the level of L4, and the junction of medial 2/3 and lateral 1/3 was the needle insertion point. Needle is supposed to strike the transverse process of L4 and redirected caudally. Now, the first two approaches were found to be too lateral, and there was a serious risk of missing the lumbar plexus altogether. The third approach was found to be too medial, and the risk of epidural spread of local anesthetic was too high. So Capdevila is currently the flavor of the day. Now, while performing this block from the back, the patient is lying in lateral decubitus position with the side to be blocked up. An 80 to 100 mm needle is used and inserted about 3 to 5 centimeters from the midline. Target is the transverse process of L4. It is, once it strikes the transverse process, needle is withdrawn and redirected either cephalad or caudally, and we are not supposed to go more than 1.5 to 2 centimeters deeper. That is deeper than the transverse process. So it's important to note the distance or the depth to the transverse process when the needle is striking the transverse process. And if we are using the nerve stimulator, we start with a 1.5 milliampere strength, and once it is reduced to 0.3 to 0.5 milliamperes, and we are still getting the patellar dance because of the contraction of the quadriceps, that is the end point, and at that point we administer the local anesthetic. So the drug used is either ropivacaine or bupivacaine, 0.2 to 0.75% ropivacaine, and up to 0.5% of bupivacaine, depending on whether you want analgesia or anesthesia, and the total volume required may be up to 30 ml in large individuals. Now, the end point of locating this psoas compartment or the lumbar plexus, when we are using just landmark guided technique with a short bevel needle, we will feel a subtle loss of resistance, which may not be as distinct as when we're doing an epidural, but it is there. With the nerve stimulator, the current strength has to be more than 0.2 or 0.3 milliamperes, and yet we should get the quadriceps contraction. And when we're using ultrasound guidance, the spread of local anesthetic is there under vision. Now talking about the ultrasound guided lumbar plexus block, we can use either a curvilinear probe or a high frequency linear probe depending on the approach and the body habitus of the patient. Now, with an out of plane paravertebral sagittal approach, we use the ultrasound probe, which is kept just by the side, longitudinally by the side of the midline of the spinous processes on top of the transverse processes, so as to elicit this trident sign as described by Karmakar. And So between any two transverse processes, we find psoas muscle, and as described in the previous slides, the lumbar plexus is supposed to lie in the plane between the posterior 1/3 and anterior 2/3 of the psoas muscle. So it also gives us a fairly accurate idea about how deep to go. Remember, if we go too deep, we may end up causing some harm, um, as in renal hematoma or causing renal injury or retroperitoneal hematoma, because remember, it's a very vascular space. So once we have, so needle insertion is outer plane according to the depth as we see on the ultrasound image. And once we are there, we deposit the drug. Now the other approach, since the previous one, we could not see the whole needle. This approach, shamrock approach, has been described, in which the whole needle is seen entering the psoas compartment. So the patient is lying on the side. As you can see, the ultrasound probe is kept on the flank, trying to delineate the body of L4 and the transverse process. The transverse process of L4 is the largest among the lumbar vertebrae, so that it's easy to delineate. And once we have this vision, this image, the block needle is inserted from the back, again about 3 to 4 centimeters from the midline, and we can see it enter under vision, and we can see the whole needle with ultrasound as it enters the psoas muscle, and there under vision we can do the local anesthetic deposition. Now, this is a very challenging block, not an easy block, and it has its own complications like epidural spread, especially if we do the injection with a lot of pressure. It is bound to go into the neuraxis and cause an epidural spread as well. And as I mentioned earlier, it's a very vascular space, so we need to be very careful while injecting the local anesthetic. We have to do frequent aspirations, check aspiration, and the injection has to be in small aliquots over 3 to 5 minutes, not an immediate bolus. The other complication, as I mentioned earlier, can be hematoma because it's a vascular space, and the kidney, remember, if we miscalculate the level of the spinal level at which we have inserted the needle, and if we are by mistake above L2 and the patient is taking deep breaths, then the lower pole of kidney comes and goes at that level, and we can cause some renal injury. And of course, last but not the least, local anesthetic systemic toxicity. It is more in uremic malnourished patients, as the free fraction of the local anesthetic is more because of lower albumin protein levels in the blood. So we have to calculate the maximum permissible dose, and we also have to ensure that a lipid rescue is available at hand. Now we come to the anterior approaches to lumbar plexus, which have been described. So these are enumerated here, and we'll go over them one by one. 3-in-1 block was described by Winnie in 1973. It was touted as low approach to lumbar plexus, and we were supposed to deposit large volume of local anesthetic in the femoral sheaths with the hope that it will track proximally and go right up to the lumbar plexus level. However, it has been shown that the local anesthetic spreads laterally under the fascia iliaca and rather than going up proximally, migrating towards the plexus. So, in fact, in reality, it is rather a two-in-one block where femoral nerve is blocked 90% of the times, lateral femoral cutaneous 60 to 70%, and obturator is less than 50% of the times. Fascia iliaca block is a modification of the same, and it was described um, as yet another anterior approach to lumbar plexus. It has been used to position patients for spinal block, patients with hip fractures who would otherwise find it difficult to turn or sit up. Um, it is also a useful modality for post-operative analgesia following hip and proximal femur surgeries. And it's useful when a thigh tourniquet is to be used combined with high sacral plexus block. Landmark guided fascia iliaca block. We draw a line joining the anterior superior iliac spine to pubic tubercle, divided into three parts, and the junction of middle and lateral thirds is the point where the needle is inserted. And remember, we have to go through two fascial clicks, fascia lata and fascia iliaca, and then about 30 ml of the local anesthetic is deposited. Because it's a fascial block, we have to have large volume. Ultrasound guided fascial iliaca block, a supra-inguinal approach, is supposed to be better. In this, the high frequency linear probe is placed longitudinally lateral to the femoral vessels, looking to elicit this bow tie or hourglass sign. The hourglass is formed by sartorius muscle in the thigh and by the internal oblique muscle in the abdomen, where the two tendons kind of meet. That is the waist of the hourglass, and underlying this hourglass is the iliopsoas. And it's a very effective block, simple block to give. The needle insertion is always caudal to the inguinal crease. That means the needle should not enter the abdomen, but yes, the catheter that is threaded goes high up, travels under the fascia iliaca, over the iliacus muscle, goes up into the pelvis. And this is one of the few indications where a long length of catheter in situ is desirable. So we end up placing as much as 10 to 15 centimeters. And you can travel in the bottom left figure. The catheter is easily visible floating in the local anesthetic hypoechoic image, and it's going up it's going up right there under the internal oblique, and this is the cephalic part, this is the caudal part, and the catheter has traveled right under. The needle ends there. This is the waist of the hourglass, and this is the flare of the internal oblique muscle. Coming to femoral nerve block, femoral nerve is the largest branch of the lumbar plexus, and as it travels in the pelvis between iliacus and psoas, as you can see here, at the level of inguinal ligament, it is lying lateral to the femoral vessels, but remember, it is not in the same fascial plane. It is separated by these vessels by this fold of fascia, and it is lying in a sulcus on the iliopsoas muscle. The landmark technique to do femoral nerve block is that we again draw a line from ASIS to the pubic tubercle, and on this line or just under it, we go 1 centimeter lateral to the femoral arterial pulse. The needle feels 2 pops as it goes through the 2 fascial layers. We aspirate, check for any accidental intravascular placement. Once it is negative, Then we inject the drug, and if you're using the PNS, then we have to see the quadriceps muscle contraction and the patellar dance. About 20 to 30 ml of local anesthetic is deposited, and the strength varies again whether you're looking for anesthesia or analgesia. With the help of ultrasound, it can be done using a high-frequency linear probe, which is kept parallel to the inguinal ligament, looking for the vessels, femoral vessels, and the nerve is hyperechoic, triangular, just lateral to the uh, femoral vessels. Needle is inserted in plane, laterally to medially, and the ideal position of the needle tip is under the nerve. There. These are the femoral vessels, and this is lateral, this is medial, and the needle is supposed to come like this. The risk involved with femoral nerve block is that it is for post-op analgesia, say for post-THR, it is not as effective as a lumbar plexus block. Of course, it results in decreased quadriceps muscle strength since the motor supply, the nerve supply is coming from the femoral nerve. And hence, if the patient is made to walk too soon without assessing the motor strength, there have been increased incidence of fall. So to counter that, an adductor canal block came into being, and it has been used quite successfully for post-TKR analgesia combined with something else, which we'll again come to later. So adductor canal basically is a subsartorial canal, also known as Hunter's canal. It is bounded superiorly by the sartorius muscle, medially by the adductor magnus or longus, depending on how high or low you are in the thigh, and laterally by vastus medialis muscle. And it is supposed to contain the vessel, that is superior femoral artery and vein, the saphenous nerve, which is a sensory branch of a femoral nerve, and also the nerve to vastus medialis. So once you block these two nerves by giving this block, it results in very good analgesia. Also does not result in as much motor weakness, so the patient can be made to stand up and walk as early as 3 to 4 hours after the surgery is done. That is total knee replacement. Lateral cutaneous nerve of the thigh arises from L2 to 3. It's a purely sensory nerve, and it enters the thigh medial to ASIS. However, it may branch before it enters the thigh. It crosses over or sometimes goes through the sartorius muscle. And by the time it enters the thigh, it is already pierced through fascia iliaca, and it lies at this location, lies between the two fascial layers, lata and fascia iliaca. It may be absent in 7% of human population. It's usually very small, measuring just a couple of millimeters in diameter, but we have seen that in myalgia parasitica, it tends to go very big, as much as nearly a centimeter. 5 to 10 ml of ropivacaine is sufficient to block this nerve. Now, with the help of landmark guidance, we go 2 centimeters caudal and 2 centimeters medial to the ASIS. The needle goes in through just one pop, that is fascia lata, and we deposit about 5 to 10 ml. And with the help of ultrasound, we use a high frequency linear probe. It's quite a superficial nerve, as you can see here. The total depth of the screen is just 3 centimeters. So we look for this triangular or oval shaped image of sartorius muscle. The ASIS is somewhere there, and in fact it is a little more proximal. TFL, the tensor fascia lata, is a small muscle lateral to the sartorius, and there is a fat-filled pocket here between these two muscles under fascia lata, which is supposed to contain the nerve. So sometimes we see this nerve, sometimes we don't, but we always see this fat-filled um, area where we are supposed to deposit the local anesthetic for this block. Coming to obturator nerve block, obturator nerve supplies all the adductors of the thigh except the pectineus, which is supplied by femoral, and adductor magnus, which receives dual supply uh, from sciatic as well. Now, this block is used for hip surgeries, for knee surgeries, where posterior division sometimes in about 30% of population supplies that a knee joint. It's also useful in spasticity of the adductors, and also in spite of giving spinal anesthesia for a TURBT. That means bladder tumor, especially when it is stuck to the or arising from the lateral bladder wall. That is where the obturator nerve courses through. So when the surgeon applies diathermy there, the nerve can get stimulated, direct stimulation, and that can result in adductor spasm. And surgeons have been kicked in the face. So in spite of spinal, we do give this particular nerve block when we know that the tumor is arising from the lateral bladder wall. Now it has, as it comes down from the pelvis into the thigh, it divides, and this division is intrapelvic in 25% of population, in the obturator canal in 50%, and in the thigh in 25%. It gives out two divisions, anterior and posterior, which run between the adductor muscles, as we see here, the longus, brevis, and magnus. And now for landmark guided approach to obturator nerve block, we feel the pubic tubercle, go about 1.5 centimeters caudal and lateral to it, and the needle then is supposed to hit the superior pubic ramus, withdrawn, and then redirected a little laterally and behind the pubic ramus so as to enter the obturator canal. Enter about a couple of centimeters beyond the pubic ramus and deposit 10 to 15 ml of drug there. With the help of ultrasound, it's very easy to do this, perform this block. We don't actually see the anterior and posterior divisions as they are separated by adductor brevis. So we find in the medial aspect of the thigh, medial to the femoral vessels, as the pectineus is getting out of view, we find these three muscles, adductors, adductor longus, adductor brevis, and adductor magnus. And between, there's the facial plane between the two adductors here and the two adductors there, we find the anterior branch and the posterior branch, which may or may not be visible like this. So we just target this plane and deposit the local anesthetic there. It can be an in-plane or out-of-plane approach. So it can be either two separate injections, or we can just, same needle insertion, we can just target the deeper, that's the posterior division first, and on the way up, it can, the needle can, once it enters this fascial plane, then this can be taken care of as well. That is the probe position. Coming to the sacral plexus, it is formed by the nerve roots from L4 to S3. And the largest branch that it gives out that concerns us is the sciatic nerve. Of course, there are several small branches as well. And as I said, the posterior femoral cutaneous nerve is another small nerve which is of importance to us. The parasacral approach is the highest approach to sacral plexus block. It was described by Mansour in 1993, in which he said, you draw a line from the PSIS to the ischial tuberosity, and about 6 centimeters caudal to PSIS, that is the needle insertion, and go straight in. And with the help of PNS, you can look for um, uh, ankle movement as the sciatic nerve is stimulated. The sciatic, once it is formed in the pelvis, it comes out from under the piriformis muscle, and that is, before it comes out from under the piriformis muscle, this is where we target it in parasacral approach with the help of ultrasound. Again, it's not a very easy, but yes, it's not very difficult either. So with the help of low frequency curvilinear probe, because it can be relatively deep, especially with people with big buttocks. So we start with the probe about 8 centimeters from the midline, from the start of the gluteal cleft. It is kept on top of the ala of the ilium, and then it is sit down looking for this gap which comes, and then we see the sciatic nerve right there under the piriformis here. And the needle is inserted again in plane or outer plane, and this is where we deposit the local anesthetic. And since it's a very high approach, it results in practically blockage of the whole sacral plexus, and some obturator nerve sometimes is also involved in this approach. Coming to a little lower down in the buttock, the subgluteal approach, as described by Labat and modified by Vinny later, we draw a line from PSIS to the greater trochanter of the femur. From its midline, we drop a perpendicular to meet a line which is joining the greater trochanter to the sacral hiatus. And where these two join, that is the needle insertion point. With the help of ultrasound, the ultrasound approach was described by Karmakar, in which he said a subgluteal space exists. So just beneath the gluteus maximus muscle, where the fascia ends, there is a subgluteal space which is supposed to target when we do this block with the help of ultrasound guidance. And as you can see, that is the sciatic nerve lying in the subgluteal space on top of the quadratus femoris muscle. So as it comes out into the buttock from under the piriformis muscle, from the greater sciatic notch, it lies over the superior gemellus, the obturator internus, inferior gemellus, and then the quadratus femoris muscle. So this is where we target it, between the greater trochanter and the ischial tuberosity. Now, some unusual approaches to sciatic nerve: lateral, inferior, and anterior approach, and these are all to be done with patient lying supine position. The lateral approach were described for pediatric age group, in which a line is drawn passing through the greater trochanter towards the iliac crest, and in the lower junction of lower 1/3 and upper 2/3 is the point where we insert the needle with slight about 15 degrees posterior angulation, looking for this nerve with the help of PNS stimulation. Professor Raj described a technique where a helper or an assistant holds up the leg of the patient flexed 90 degrees at the hip, and on a line joining the greater trochanter with the ischial tuberosity. In the midline, in the midpoint of this line, we insert the needle, again looking for a contraction of the ankle, movement of the ankle. The anterior approach is useful sometimes when the patient cannot be moved because of injury. And Beck described it in 1963. He joined the ASIS to the pubic tubercle, and from the medial 1/3 and lateral 2/3, he dropped a perpendicular on this line, joining the greater trochanter to the lesser trochanter, or which is actually running parallel to this first line. And but the problem with this approach was that the needle ended up hitting the femur more often than not, and it um, so Soron and Delaunay, they described yet another approach in which from the femoral pulse, 6 centimeters caudal and 2 centimeters lateral is the needle insertion, and it goes straight in to hit this sciatic nerve. Now, sciatic nerve in this location at the level of the lesser trochanter can be seen with the help of low frequency curvilinear probe of ultrasound. And it is said that the depth is roughly double of from the skin to the femur. So this is roughly double. And of course, it helps by externally rotating the thigh at the hip if it is possible to reach this sciatic nerve, which is partly hidden underneath the upper part of the femur. Coming to popliteal tibial nerve block. Now we know that as the sciatic nerve descends at the back of the thigh towards the popliteal fossa, where it divides into common peroneal and tibial nerve. Now, if we draw the boundary of the popliteal fossa from the base of the popliteal fossa, or the popliteal, the crease at the back of the knee, we go about 5 centimeters up towards the apex of the popliteal fossa, popliteal triangle, and we insert the needle. The other approach that is described is from the lateral side of the thigh in the groove between the biceps femoris muscle and the vastus lateralis muscle. So we are targeting the popliteal nerve right here. With the help of ultrasound, it is easy to see that we can target it here at upper in the back of the thigh, where before it divides into the two tibial and common peroneal, or we can also carry out selective nerve block. Like in the case of post-TTR analgesia, we do a selective tibial nerve block, combine it with adductor canal block so that patient can be made to walk. If we were to do a common popliteal or a sciatic nerve block at the back of the thigh, the patient will end up with an ankle drop and will not be able to walk. Coming to ankle block. Now, there are 5 nerves which supply the ankle: the superficial peroneal, deep peroneal, sural nerve, posterior tibial nerve, all 4 coming from the sciatic nerve, and then the saphenous nerve, which is a continuation of the femoral nerve. Indications would be any surgery on the foot and ankle, like forefoot amputation, reconstruction, osteotomies, bunion surgery, or analgesia in case of trauma. Or it can also be a diagnostic, a therapeutic block in case of spasticity, like in clubfoot. And these are the distribution. We know that deep peroneal supplies only this bit of the skin. Of course, it supplies most of the muscles inside, but this is the dermatomal spread. Saphenous on the medial side of the thigh up to the medial malleolus and lower down a little bit. This whole thing is supplied by the sole is supplied by the posterior tibial nerve, while sural nerve is on the lateral side of the foot. So for landmark guided ankle block is quite a simple technique. We have to do just 3 injections to target these 5 nerves. The easy way to remember is I find that 3 S's to be covered by 4th S, that is saphenous nerve, superficial peroneal nerve, and sural nerve. They can all be covered by a single subcutaneous infiltration from medial to lateral malleolus of about 15 ml of local anesthetic in a circumferential manner. And on this very line, in the at the anterior aspect of the ankle, we can target the deep peroneal nerve, which lies deep to the external retinaculum between the external hallucis longus and external digitorum longus. 5 ml is sufficient. And posterior tibial nerve is targeted deep to the flexor retinaculum, midway between the medial malleolus and Achilles tendon, posterior to the posterior tibial artery. Again, 5 ml is sufficient. Those who are very enthusiastic about ultrasound usage can use ultrasound guidance to target the two deeper nerves, that is the deep peroneal nerve at the anterior aspect of the ankle or the lower part of the tibia. We see the anterior tibial artery, and right next to it, we find the deep peroneal nerve, medial to it, between the two tendons, as I said, external hallucis longus and digitorum longus. And for posterior tibial nerve, we place this high frequency linear probe like this above the medial malleolus, overriding it and going behind towards the Achilles tendon. There we look for the posterior artery, and the tibial nerve is lying right behind it. So again, very easy to see. And for the rest, the other three, as I said, subcutaneous infiltration of local anesthetic in a circumferential manner is more than sufficient. You don't need to go for ultrasound guidance. But yes, techniques have been described, though I'm not describing it here. Now to the last bit of this presentation. If you have really smashed your Viva or so far on the lower limb blocks, these two are very new blocks which have been described. PENG block for hip and IPAC block for knee. The basic premise is that the final articular branches, which are so fine, too fine to be seen with the help of current technology of ultrasound, but we know that they must be passing through a plane right adjacent to the joints. So in the case of hip joint, you see when we put a probe high up on top of the ilium, we see the ilial protuberance here. We see the femoral vessels here, and we see the iliopsoas tendon right there. So the needle comes in from lateral to medial, and we deposit the local anesthetic in this plane, and we see this whole plane opens up, and like I said, the nerves must be traversing through this plane, which are too fine to be seen, but they obviously get blocked, and we find this block extremely helpful. It is more effective, let me tell you, than femoral nerve block when we make patients sit up or turn lateral in order to give spinal. These patients have proximal femoral fractures, femoral neck fractures, and they find it the movement extremely painful. In fact, we have placed catheters as well in this plane in those few patients who are very sick to be operated straight away. They need to be optimized for a couple of days before we take them up for surgery. And Sanjay Sinha described this IPAC block. So instead of giving a selective tibial nerve block, as I said, in combination with the adductor canal block. So selective tibial, what it does, it takes care of the pain arising from the posterior capsule of the knee joint. So what this IPAC does is something similar, maybe more effective, because it is targeting this plane at the back of femur right here. These are the popliteal vessels. Right at the lower end of the femur, we see a needle coming in plane, going from lateral to medial side, and as we withdraw the needle, we keep depositing local anesthetic, which opens up this plane, and the nerve, remember, is right there, popliteal sciatic nerve. So Logic says that all the nerves coming to the joint must be traversing through this plane, and as this plane opens up with local anesthetic is flooded, so all the nerves which are traversing this plane logically should be blocked, and they are. Believe me, it's quite an effective block. So with this, we come to the end of this presentation. I hope I've done justice to it, and I look forward to your questions, and I'll be there to answer them. Thank you very much.